Hey, Section 3, here is your Week 6 wrap-up. So first of all, our shout-outs. We had a lot of people do a really great job this week, and we want to recognize each of you. So Nicole, Kristen, Nate, Gabe, Will, Catherine, and David, excellent job in your respective groups. You guys got a lot of great discussion going on. I saw lots of response posts, much more than they're required to. So great job just getting in there and discussing this, and I'm sure you guys benefited because of your level of participation. So, and the others around you did as well. So thank you. So this week we talked about cervical radiculopathy. This would be our centralization category of our treatment-based classification. In general, this group will do well with traction, either mechanical or over the door. Manual traction wasn't tested in this. But anecdotally, manual traction can be beneficial as well, and can affords us the ability to be a bit more specific on what we're tractioning anyway. Centralizing maneuvers. In our required readings, we had a systematic review that showed that MDT was not beneficial for this category, but there will be a significant portion of this group that will benefit from those centralizing maneuvers, whether those are cervical retractions, whether those are contralateral side bends. If you find that with a patient that any maneuver centralizes their symptoms, then that's gold. You found that little piece of gold there, and I would work that as much as I could. We also saw that neural tissue management is beneficial for maybe even those that don't have a classical cervical radiculopathy but do have arm-related pain from some neural dynamic issues. So many of us are not very comfortable with doing this, and I think that we've been a little jaded, whether we've tried to use it and it just kind of backfired in our face. But there are yellow lights and then there are red lights, as I like to say. If you reproduce some of those distal symptoms, that could in fact be a good thing, as long as you can get them to centralize, or once you've reproduced them, if you're gaining range of motion as you're mobilizing that nerve. And when you stop the maneuver, the pain relieves within 10 seconds is usually what I use. Then I consider that a yellow light, and I'm going to proceed with caution. If that pain stays longer than 10 seconds, then I consider that a red light, and we're just not ready for that yet. Or I'm mobilized too aggressively at that point, and I'm going to try again the next session. It's also important to note that not everybody has the same dermatomal map, and not all C6 cervical radiculopathies are going to look the same. Some are just going to have pain above the elbow. Some will have pain below the elbow. Some will have that classic radicular pattern that goes down to the thumb. So keep that in mind, and that not all these folks are going to respond the same. Some actually I've seen do very poorly with traction, and then I can find a centralizing maneuver and I just kind of push that and get them better that way. And some never really do respond to that traction, but by and large most do. Okay, so we have cervical myelopathy. I think most of us were surprised about the high number of older adults that do have cervical myelopathy, and I think we've all seen a lot of patients in our clinic that walk like this video on the left. Now that's not just to say that they have some neurological disorder and or cervical myelopathy. There can be multiple reasons for wide base gait, but that may perk your ears up a little bit and make you investigate a little bit further. The cluster of tests is not in itself sensitive enough to screen out all of these patients, right? So the sensitivity of these tests are not excellent. The specificity is a bit better than the sensitivity, so much better for ruling in those conditions than ruling them out. But here on the left, we have a Hoffman's. I had not seen one of these until my residency training, but you get that flexion of the first and second digit there, and then the inverted supinator, inverted supinator sign on the top video, where you're hitting brachioradialis and you get flexion of your fingers. So coming up for week 7, I have made visible the objective portion, the physical exam for your group projects. You should be able to see that under week 7. Jason and Tim Flynn have added an optional presentation, cervical dry needling, and that it will be, you can get that through the original link for the course Dropbox or on the weekly link to week 7. He's added it in there, and I'll add it in the link in on the announcement for this. Fit case discussions will be ongoing. Those were turned in last week. And then week 7 topic, we have whiplash associated disorder and motor training. Certainly when I just moved from Atlanta, and there was a lot of car accidents in Atlanta. I haven't seen as many here in Utah, but that was definitely a high proportion of my population at that time. So a good week topic and weekly topic, and something that I think we all can relate to and we have all been frustrated by. So that's it for week 6, and I look forward to seeing you on the boards. Let's keep up this great discussion. I'm really loving it. So.